they're just on their way, just waiting for everything to kick into gear.
So if it's all right, if we'll just start now. Again, sorry about the delay. So this week we're going to do go through a PowerPoint on anemia. Do you mind going to the next slide, Jack? So first of all, we're going to go through some cases and discuss them. So about 4 or 5 cases. I guess stuff that you might encounter on call on the weekends or in the evening shifts, and then do a brief overview of the classification of anemia, and then discuss some sort of common causes if that's okay. So we'll just move on to the first case. But if you have any questions at any time, just let me know or stop me. So again, these are all scenarios that you're on call over the weekend covering hematology. And so the first one is you're seeing you've been called by the nursing staff. The first one is a 57-year-old gentleman. He's got a background. He's got refractory Hodgkin's lymphoma, and was initially admitted for an allogenic stem cell transplant. So allogenic, so stem cells from another recipient. And he's currently in day +4, which means so sort of 4 days post the stem cell transplant. And the laboratory has just phoned through some blood results and says their hemoglobin's 65, but no other results at the moment. And can we go to the next slide? I just want to discuss through some of these questions, if that's okay. So what was any other information you want to know at the moment with that blood result of HB of 65?
Are they bleeding? Is that one of them?
Yeah, exactly. Yeah, that's a very important one. Yeah. So this chap's he's not bleeding, no.
What the baseline is?
Yeah.
Based in terms of observations.
Sorry, in terms of previous results.
Yeah, that's important. So I guess it's important if someone's HB the day before was 70, you're not going to get too concerned. But if their previous HB was 100, 120, say, then you're going to be worried, is there an occult, bleed that we're missing? So we'd say in this case, this patient's hemoglobin the day before was 72. Anything else you'd want to know?
My other question is, would I want to know if they're a known anemia, if you know what I mean, pernicious anemia of chronic disease? Is that could be that, or would they not have that?
So probably not in this scenario as such. This patient's had is coming. They've got a good reason to be anemic after chemotherapy and then the stem cell transplant. So this patient's got a good reason to be anemic in this case. So this wouldn't be an unexpected blood result in this patient. This wouldn't be out of the ordinary, this result.
Would you want to know if they were clinically stable? So what their odds and whether they're symptomatic with it?
Yeah, exactly. Yeah, that's important. Yeah. So I would say for this patient, they're hemodynamically stable. They're not tachycardic and their blood pressure is preserved. And he's apyrexic, not on any antibiotic therapy. And there's just one other thing I'd probably want to know maybe. And I was thinking about, was there I want to know if there's a history of heart failure or end-stage renal disease or cirrhosis, but I guess especially that heart failure and just if we're going to be transfusing him. And then just going to the rest of the questions, what threshold would you use for this to give a red cell transfusion, and would it differ at all in hematology and hematology patients?
The trust guideline says less than 8. So in a hematology patient, I think it would be the same.
What level did you?
Is it less than 8? 80?
Yes, that's certainly for hematology. That's what we would use. Yes, that's sort of the golden number. Yeah. And then if you were to give him blood, how many units would you give the patient, and over what time period?
I think I'd give 1 unit over 4 hours.
Okay.
But I don't prescribe blood, so I'm not
sure. Yeah. Anyone else have anything else they would do, or anyone else's opinion?
Just give it like a unit over 3 hours. Just give it slow.
Yeah. And then thinking about special, we'll go through each of these questions again in more detail, but and then we can cover the special requirements as well. Do you think this patient would need any special requirements for blood?
I'm inclined to say yes, but I don't know what they'd be.
Yes, no, you're right. Yes, but we'll go through all that in more detail. Do you mind going on to the next slide, Jack? So I know there's a lot of information on this slide, and this is from the NICE guidelines on blood transfusion. And essentially, what it's really saying, and what I was always taught from a sort of a general medical perspective, was to use a transfusion target of 70 in sort of non-hematological patients. But then to use a slightly higher threshold if they're symptomatic or there's a history of ischemic heart disease. But I think what's highlighted at the bottom is important, is that hematology patients are slightly different to general medical patients I found when I did hematology. And if we just go to the next slide. So yeah, just as mentioned before, if there's not a lot else to take from today, I think yes. So on the hematology wards, we would use a transfusion threshold of 80 rather than maybe 70 in a general medical patient.
I think it's probably important at this point to say that there's no particularly special reason why we have this threshold. It's entirely historical and entirely cultural. I think when so there's kind of trying to split this sort of anemia up into different things. So I think attacking a patient who's already an inpatient, particularly on a hematology ward, who's anemic, I mean, the causes of that anemia are only really 3 things: either they're bleeding, they're hemolyzing, or it's supposed to be like, oh, it's a result of their therapy, or it's chronic. So you're unlikely to sort of have to do that full workup in the first instance when talking about other types of anemia. And then really what you're trying to decide, and I think what Jack's trying to point you towards, is when to intervene. So the most important things are they bleeding? Because usually those people need transfusing. And then what is your threshold for transfusion? So as he pointed out, I would say that your threshold for transfusion for most patients should be less than 70. It doesn't always have to be. If there's an obvious cause for that anemia and the patient's not compromised, then you could actually not transfuse at all. So actually a lot of it's to do with clinical decision making and assessment of the patient, as some of you have already mentioned. But I just want to clarify that the threshold of 80 is actually a bit of a stickler for some of the transfusion specialist nurses, and there's some work going on to try and change that, but at the moment they've been unsuccessful. Sorry, Jack.
No, that's right. No, that's really helpful, Jack. And then if we just go on to the next slide and sort of think about sort of how many units we give and over what time period. So I think, as said before, I think it's really important, not to go overboard with prescribing blood. And again, this is back to the NICE guidelines on blood transfusion, and again it does state to consider single unit blood transfusions for a patient. And then the other key thing is to review a patient after a blood transfusion. And again, we'll come to this, why this is so important, and the consequences if you don't later on in the presentation. And then if we go to the next slide. So yeah, that's just a
well, I don't know where Jack's gone, but oh, okay. Sorry, Jack.
Yep. Hello.
We can hear you.
Yep. So again, saying, you know, it's important if you're going to give more than one unit of red cells, it's important to review the patient after that first unit, and it's and again, we'll go into why that's important later on. And as we say, we'd usually give a unit of red cells sort of between 2 to 3 hours is how long we prescribe it over. And then if we go on to the next slide. And again, so there's, I think what a really good thing is when you're thinking about whether the patient needs any special requirements for blood, is the transfusion lab are really on the ball and know and really know a lot of this information. But I guess just for your own information, so so patients like Hodgkin's lymphoma patients or stem cell transplant patients, you know, on the ward, then they need irradiated blood. But again, usually when you phone the lab, they'll have all this information and will know this, because the patients on the ward are getting blood and platelet transfusions on a very regular basis. So we might move on to the next case.
Can I just ask what the significance of blood being radiated in these like the non-Hodgkin's patients?
What was that, sorry?
Can I just ask what's the significance is the blood being irradiated in sort of like the non-Hodgkin's patients? Why do we give them irradiated blood?
In the Hodgkin's patients,
you said in specifically Hodgkin's patients that they would be the ones that would maybe get irradiated blood, or just in general why we give irradiated blood?
Yeah, that might be helpful, Jack.
So I think just on a couple of Jack's points, first thing is just don't give two without review. It's a big campaign by NHS Blood Transplant. I think because traditionally, again, a historical thing has always been, if you're going to transfuse someone, you might as well give them a couple of bags of blood. There are significant risks associated with that, which Jack will touch on later. So now very much the mantra is, if you're going to prescribe a bag of blood, in the absence of someone having a major hemorrhage, then really the consideration has to be given 1 unit of blood and then review the patient clinically. You could always request 2 bags of blood, but then you review the patient in between. Occasionally, you might repeat the full blood count. Make sure they're not suffering a complication, and then consider a second unit then. The majority of times on the haematology ward, you're just giving a blood as a prophylactic transfusion because their bone marrow is obliterated, and you're just keeping them topped up. So usually 1 will be enough. With respect to the specialist products, it was mentioned because occasionally this comes up as a question, particularly when you're on the ward. And as Jack quite rightly pointed out, a lot of this stuff is set up from the outset with blood banks. So either people like me or the consultants or the specialist nurses tend to get in contact with the blood bank if someone's about to embark on certain treatments and let them know about any special requirements. So generally speaking, blood bank will know best, and they're a very good source of information. And if they don't have a flag, then the important thing is, if you're not sure, is to ask, and that usually means asking people like me. And then to answer the question that got asked, irradiated blood products. So if you irradiate, so when you take a bag of blood, generally it's red cells only, but occasionally, well, not occasionally, but nearly always, there'll still be a few white blood cells floating around in the bag of red blood cells. For the vast majority of people, that's absolutely not a problem. Our immune system deals with those sort of 1 or 2 white blood cells that are not ours and sort of eats them up before they cause a problem. But in a particular cohort of patients, that's either specific chemotherapies, stem cell transplants, certain immunotherapies, an actually Hodgkin's patient, their immune system is not equipped, because it's so immunosuppressed, to deal with those foreign white blood cells. So actually what can happen is they can cause something called transfusion-associated graft versus host disease. And I think the few cases over the last 5 years in which that's happened have been sort of universally fatal. So we do try and avoid that if at all possible. And the way to do that is to irradiate the blood. So you basically blast it with radiation. It kills nucleated cells. It kills white blood cells but preserves the red blood cells. So you're effectively getting rid of the white blood cells. There's various reasons why actually that might not be as important these days. But as far as you're concerned, one, ask blood bank. Two, if you're not sure, ask us. But most of the time it's already sorted, and I think that's the takeaway point. Sorry, Jack. Two.
That's right.
Can I ask another question? Sorry, Jack. Would we investigate this patient for anemia, like do hematinics, or is that not required in these kind of patients?
No, I wouldn't investigate that. No, so this, yeah.
Go for it, Jack.
No. So I wouldn't check hematinics in this patient, because they've got a good reason to be anemic. So no, not in this instance.
Okay, thank you.
And then if we move on to the second case, so again, this is sort of a weekend thing, and you're seeing you've been given a blood result for this patient. She's a 61-year-old female with acute myeloid leukemia. She was originally admitted with neutropenic sepsis and is on intravenous fluids and IV tazocin. And they're hemodynamically stable, so their blood pressure is stable and they're not tachycardic. However, they have been having 1 or 2 spikes of temperature the last couple of days. And so the blood results are back, and you've got a platelet count of 14. And can I check, what would you want to know at this time, and then what are you going to do? Are you going to give them any platelets?
Yeah, again, go through the ABCD, find out if they're stable and if they're bleeding. See if they're on fragmin. Maybe they're not. Stop that. And yeah, I would give them a platelet.
Mm-hmm. Okay. Yeah. Anything anyone else would want to know or add? Well, shall we just go through? We'll go through some of the guidance again. If we can just go to the next slide about which shows again the nice guidance around platelet transfusions. Oh, and so if we go to the next one. So again, this is quite a lot of information. But what it says at the bottom in point 1.33, it says from NICE that you would offer platelet transfusion to someone with a platelet count below 10 if they're not bleeding. So again, that's not really, our patient doesn't fit that category. And then on top, it says if someone's got thrombocytopenia, so platelets less than 30, but there is bleeding, then you would give them platelets. But again, this patient doesn't fit into that criteria. They're not bleeding. But if we go to the next slide. So I think just going through this, so if somebody is having minor bleeding, then yes, to try and keep the platelet count above 30, and if it's a more major bleeding, above 50. And I think what's in this case is relevant. So this patient isn't bleeding, and so if someone's, well, you'd use a threshold of 10, but if they're septic, so in the case of this patient, they're although they're hemodynamically stable at the minute, they're still having frequent spikes of temperature, so they're septic. So you'd use a threshold of 20. So yes, I'd give this patient a 1 pull of platelets and tend to give it over half an hour. But I think what's important to highlight, as Jack's mentioned before, if you're not sure, then to either speak to the hematology registrar or SHU on call. There's always people around on the weekends to go through things.
I think the other important thing to note, well, first thing is if a patient's bleeding with a low platelet count, then there's two things that are vital. First is, why has the patient got a low platelet count? Because actually there are some circumstances where transfusing platelets is not a good idea. In fact, it's contraindicated. So you might need some help with that. And the second thing is, if a patient's bleeding and the platelet count's low, is that someone like the MedReg or me will want to know about it. So I'd much rather be on the end of the phone helping you out and discussing it rather than sort of just concentrating particularly on those two numbers. Because actually sometimes we want a higher number than that, sometimes we're not too bothered. It depends on the situation. So I think the sort of casing point here was the routine stuff is when the patient is not bleeding and there's a clear and obvious cause for the low platelets, in this case, which is chemotherapy and leukemia, then we have these prophylactic, these preventative thresholds to prevent significant bleeding, which is what Jack's given you before. So I'll let you carry on, Jack. Sorry.
That's right. And again, this one probably is probably not so often an issue as much, but thought we'd just discuss it slightly. So it's a continuation of the same case. So it's a few days down the line, and the patient's now improved and has finished antibiotics. And is now planned for sort of induction chemotherapy, but needs a central line for it. However, the blood tests show that the platelet count is still very low at 7, and the patient's going to go for the line today. And the nurses on the ward ask, can the patient undergo a central line, or do they need any platelets at this stage? Is there anything you think about that?
I think I'd want platelets to be over 10. Would you not? Going on the last guidance, so. Obviously, we discuss it, but I think they would need some platelet cover before they add a central line.
Yeah, no, I agree. Yeah, I would. If we go to the next slide, we just go through some sort of thresholds for procedures. So it's again a little bit different if someone's getting a procedure done like a central line. So you want the platelet count to be above 20. Another important thing, so like a lumbar puncture. Whether that's diagnostic or if that's for intrathecal chemotherapy, then we'd want it to be a bit on the higher side. I think just at the minute there's a good app called Bucco Hematology, which is BUKU, and it gives a lot of these thresholds, and it covers a lot of the emergencies, and it's an app to try and that covers a lot of the basics and questions that you might have on call.
Jack, what was the name of that website again, please?
So it's BUKU. I don't know if Jack's seen it, if he wants to, if he seconds that.
It's really good. I've got it.
All right, yeah.
Yeah, it's a Newcastle app, and they designed it to try and reduce the number of calls to the hematology reg or consultant on call, and found it was actually it did really what it did help to reduce the number of calls quite significantly for routine things like how quick to give a platelet transfusion, for example.
I think that last case is important as well, because occasionally I suspect that a nurse, if you're on the ward reviewing a patient, might approach you and say, so-and-so is going for a PIC this evening. Do you think they need platelets? And I guess it just gives you that emphasis that, often naturally platelets are required. I'm more than happy to be woken up about that if it means that I don't have to sort of stress about legging it to the ward in the morning before the vascular radiology consultant comes in and sorting it out then. So it's just sort of occasionally those things might crop up. Hopefully the SHOs in their day have sorted that out, but you never know.
And if we just go on to the next, that's all right. Go on to the next case. It's a bit of general medicine in this. So it's a 78-year-old gentleman, quite frail with chronic with CLL, and again he's admitted with neutropenic sepsis. And the nurses have asked you to come and review the patient quite urgently because he's having quite severe coffee ground vomiting. And if we go to the next slide and we can see the patient's observations and things. And so when you get here, the patient doesn't look well whatsoever, and is having active, ongoing, coffee ground vomiting, and this is his observations. What do people think about those observations at the moment?
Well, they're very low.
Signs of shock.
Hypertensive, yes. Tachycardia.
Yeah,
signs of.
Yeah, he certainly seems quite shocked, doesn't he? And how would you approach this patient, and what interventions would you do at the bedside for this patient?
You need some fluid resuscitation, I would have thought, quite quickly.
Yeah. And
CG, find out his heart rate.
And
I think he's very much in that phone a friend category, isn't he?
Yeah. So again, I think you're right. Your A, B, C, D, E's, which are important, and the same things you do in any general medical wards. Of get two as big as you can cannulas in as ACF, and get some fluids going. And I just wonder if we can go on to the next slide. And I don't know if anyone's heard about the different stages of hypovolemic shock. This is quite a helpful way I find of looking at things. And so sort of stage 1, if they've had less than 750 mils lost, there's very often very little to pick up. So their pulse might be, again, they might not be tachycardic, the blood pressure is going to be fine. And then I think this patient then goes into the sort of the third category, which is quite bad. And what makes it this third category is that the blood pressure's dropped. And what we'd say, when their blood pressure's dropped, this patient's going to need blood, really. And I think what to highlight here, exactly as Jack said, it's phone a friend time, and speaking to the hematology reg on call and gastro on call, and what we really need to do is activate the major hemorrhage protocol. I don't know, has anyone ever had to do that on nights or been involved in any GI bleeds that's needed that?
Yeah.
Yep.
Yeah, I think we all have, haven't we?
Yeah.
Yeah, it's lots of drama. So this is, I know it's very tricky to see it, but this is just a sort of a diagram of the sort of the major hemorrhage protocol example, just going through things. Do you want to move on to the next slide?
Jack, can I just ask, so would you give them O negative blood, or does this patient still need irradiated blood? Would that play a part?
So I think in this one, I think it depends where you are, really. I guess if the major hemorrhage protocol, if the blood's coming, if it's going to be quick, then I would give blood through that way. If you're at a smaller district general hospital, then there may not be a major hemorrhage protocol, or it might take longer, and you would have to give sort of O negative blood. But in somewhere like the Hallamshire, you get blood quite quickly.
I think it's two things. So you can give, so O negative it can be irradiated or not irradiated. So I think there's probably two questions in that. So in terms of to give O negative or to give AVO matched or actually fully cross matched blood, then that depends on what's available at blood bank and how quickly you need it. So if you need it in an instant and there is no, and we don't know the situation with the blood grouping, then obviously it will be O negative that the blood bank gives you. It's likely this patient's probably been in for a while and we know his blood group anyway. So it's a slightly different matter. When it comes to irradiated or non-irradiated, well, if the patient needs irradiated blood, they should have irradiated blood. And often in blood bank, especially at the Hallamshire, the emergency blood products at the Hallamshire are often irradiated. So, because it doesn't matter, you can give irradiated blood to someone who doesn't need irradiated blood, but what you shouldn't do is give non-irradiated blood to a patient that needs irradiated blood. So most of the time, the stuff that's in the emergency will be irradiated as well, just to sort of prevent that ever being an issue. But again, I think, if you're going to see a patient like this on a ward who's likely bleeding with those obs, it's almost sort of 4-2, isn't it? Unless the med reg gets to you very quickly. And then I guess between the team, you can manage that patient. And if we need to come in, then we'll come in and help coordinate everything. But blood bank are good at this as well. So they'll help you out with all of that. So I think the main thing is just sort of have an acknowledgement that if someone's that poorly and bleeding, then perhaps just waiting for a couple of bags of blood won't be enough, and that this is an option as well. So Jack will talk to you about indications.
Thank you.
So this is a sort of a good definition of what a major hemorrhage is. So I guess probably in this situation you're thinking about this more than 50% of the total blood volume lost in less than 3 hours, and this patient's getting towards that stage really with their active hematemesis. And again, this patient meets probably that bottom, that clinical definition of, a systolic blood pressure of less than 90 and a heart rate of more than 110. So I think, this is a situation that warrants this massive transfusion protocol. Any questions at all at the moment? Okay, so we'll move on to the next one, and this one might sort of hark back a bit to the first case we were talking about, giving blood. So this is a case of a very frail 81-year-old gentleman. He's got a background of CLL and heart failure with systolic dysfunction on his recent echocardiogram, and is on regular furosemide. So I think this is a case actually I saw quite recently. So he's admitted with fresh PR blood and a HB of 44, and that's quite a drop from his last HB. His last HB was 92, and whoever saw him in the O2 day ward has requested 5 units of blood, and they've been sent over to the O1 ward. And so you're getting a call from the nurse. So the patient's on their 3rd bag, and says that the patient's become very breathless and tachypneic, and the SATs have dropped from 98 on room air to 88 on room air. And if somebody want to, I guess, say what they think's going on, and then then we can go through the chest X-ray.
Bilateral increased opacification.
Sounds like it's fluid overloaded.
Yeah. Overload. Yeah.
Yeah, it certainly looks like that. It's not a very nice looking chest X-ray. So what do you think? What would you do at this stage if you had assessed this patient AT and got this sort of a chest X-ray on the ward? What would you think of doing now?
I think you'd stop the blood and try and offload him a bit.
Yeah, exactly. Yeah. So yeah, exactly. Yeah, giving some stopping the blood. I think that's something I think could always be easily forgotten. I just think, let's get some diuretics into him, and but forget about the blood. So yeah, stopping the blood, giving some intravenous diuretics, and again speaking to the the registrar on call. This is a very frail chap with comorbidities, and he's not well. So what we'd call this would be a transfusion-associated circulatory overload, and it's got a very significant morbidity and mortality associated with it. And again, we'd want to give oxygen therapy as required and diuretic therapy, and the patient may even need support on CCU or HDU with CPAP or a GTN infusion. Any questions there at all?
No.
Of all the things that can go wrong with blood transfusion, TACO is the sort of single most encountered complication and quite a significant cause of morbidity and mortality. So that's where a lot of these things about don't give to without review come from.
And again, I think this is just covering what we've covered before, just because I think the best way to manage any situation is try to prevent it. And so what's often a very good thing to think about is, does this patient, and I think would have been certainly appropriate in this situation, is does someone need furosemide cover, say 40 milligrams of furosemide alongside the blood transfusion? And I think that would have been helpful in this scenario. And again, as we're saying, don't give 2 without review, and 5 units in a very frail old gentleman, that you're it's asking for trouble, really. And if we go on to the next slide. So again, you're on call on the hematology ward, and you're it's got a 75-year-old lady. She's got multiple myeloma and was admitted with hypercalcemia, which is treated with fluids and bisphosphonate therapy. And the nurses bleeped you and has asked you to come immediately to see the patient. They don't look right whatsoever. And a blood transfusion's just started, a few moments ago. And then if we go to the next slide. So again, the patient looks very flushed and is very aware that they're not well, and is complaining of some abdominal pain, chills and nausea, and that's their observations. What are you thinking at this stage?
Transfusion reaction.
Yeah, exactly. And what would you want to, any specific type of reaction?
Transfusion related.
Yeah. And what would you want to do at this stage? What would your initial thoughts be?
Stop the blood.
Yeah, yeah, that's probably the most important thing. Yeah.
Get reviewed.
Yeah, obviously an urgent review. Probably want to give him some paracetamol with some hydrocortisone, maybe. What else do we give him?
Coffee.
Did we give him Piriton? I can't remember. Do we give Piriton for that?
Well, we'll maybe go on to the next slide and we'll talk through what we think is going on in this patient. And so I think in this case, as you said, we want to stop the transfusion immediately, and keep that IV open with some normal saline. And I think what's really important here is then to make sure you got check the patient's identity against the blood pack and make sure it's the right patient and the right details, because if not, obviously this is what could have led to this scenario. And I think the next point we were saying about bloods, we're checking the LDH and hepatoglobulins and DAT. What we're thinking there is could this be an acute hemolytic reaction? I'm also checking blood culture. Could this have some sort of bacterial contamination? And again, we want to speak to the lab urgently and get the pack sent down for investigation. And again, this is a patient that's got this very high morbidity and mortality associated with this. So we want to speak to the hematology reg and keep a very close eye on the urine output and possibly liaise with critical care if there's any reason for organ support. And so if we go to the next slide.
Somebody just asked the question, Jack, what is DAT? Catherine and Javid have asked that question.
Well, we're going to cover that at a later basis. Do you mind if we cover that later on, or? Yeah,
that's fine. We'll cover it.
Okay.
Just asked it, yeah.
Yeah, so I should have been through a bit more detail. Yeah, but we're gonna speak about hemolytic anemia later on, if that's okay.
Yeah.
So I think this situation is what we thought was a acute hemolytic transfusion reaction, and this was due to sort of mismatched ABO incompatible red cells, which reacted with the patient's antibodies, and this leads to a sort of a systemic inflammatory response, which can lead to someone being in shock, acute renal failure, or DIC. And again, that's why it's important to make sure blood samples are correctly labelled and that the right patient is getting matched the right bloods, and that's why I want to check afterwards to make sure it's all correct. And then if we go to the next slide.
Most near misses are because of wrong blood in tube, so wrong details of the wrong patient on the tube. But anyway.
So again, this is, I know it's very tricky to see, but this is just quite a helpful flow chart I saw that goes through what to do with complications after a blood transfusion, and so the right hand side covers sort of more mild reactions, and the left covers more severe reactions. But we'll just talk through some of those on the next slide. So I think I think just missed that. So I think as we said, so you can get mild transfusion reactions. So a raise in temperature of sort of 1 to 2 degrees, or an isolated temperature above 38, and you can give some antihistamines but continue the transfusion. Or if it's a rise of sort of more than 2 degrees or above 39, as that chart showed, then to give again antihistamine therapy, but to slow the transfusion down. You can get allergic reactions, and again that can go from widen the spectrum from very mild with antihistamine therapy to full-blown anaphylaxis, which again would require adrenaline and steroids. And again, as that third one is what we sort of talked about, ABO incompatibility. And then the next one again is another serious one I want to watch out for, and it's more common with platelet transfusions, is bacterial contamination of blood, and again you want to cover this patient, do blood cultures. If you suspect someone that's pyrexic, is to do blood cultures and give broad spectrum antibiotics and get the sample sent to the lab to be analysed. And then TACO is what we've covered really, and then transfusion-related acute lung injury is a very severe reaction when someone becomes hypoxic and hypotensive, and what's different to TACO, it's not really as responsive to diuretic therapy, but needs supportive therapy and has a high morbidity associated with that. Is there anything else you'd want?
Sorry, Jan.
No, go on ahead. Sorry.
I would say interesting thing about Trali is that it's typically associated with plasma rather than blood. It's to do with no one really knows why it happens, but it's probably to do with antibodies to white blood cells. And actually, what's perhaps most interesting is that the rates of Trali have reduced significantly since NHS-BT stopped using female plasma. There's a few things that changed at the same time, so they think that might be why. But having said that, they're going to stop that practice now, and there's going to be all sorts of plasma kicking around. So sort of one to watch out for if someone becomes quite hypoxic. But that's definitely one for me at the end of the phone / at the end of the bed.
Mm-hmm.
And so that's us really finished with the cases, and we're just going to go through sort of an approach to anemia, which is this isn't really as such. This is probably more to sort of an outpatient or a new patient with anemia sort of approach. And so the way that we tend to think about anemia is sort of in terms of this, in the size of the cell. So microcytic. So the most common one, and one we're going to talk about, is iron deficiency. The next one is anemia of chronic disease, which is we usually associate that with normocytic, although that can be microcytic. Thalassemia traits, which we're not really going to go into any detail about them. Normocytic can be a sort of like an acute brisk bleed, so a bit like that patient that had the coffee ground vomiting, someone that's bleeding quite acutely. Or a mixed hematinic deficiency, so that would be a combined iron and folate and B12 deficiency. And another cause is...
Do you all know what we mean by microcytic, normocytic, macrocytic? Do you all know how we get that?
Jack, would you just be able to cover it just for people who are maybe not able to speak up?
Yeah, we can.
I think. Oh, sorry, I'll never know which Jack you're talking about. I think. So this bit is more that kind of like diagnostic approach. So none of this is set in stone. Just because someone has a microcytic anemia doesn't mean they can't have something else going on. It's all diagnosing anemia is a bit of a nightmare and a bit more of an art than a science. but there's obviously some general rules you can follow. So obviously, to start with, you have a low hemoglobin, and then the first thing that you should look at, not necessarily with your sort of on-call situation where someone might be really poorly, but more with that sort of someone comes through, I don't know, SDEC, or say if you Clark someone, I don't know, and you're anemic and you're wondering why, or you might be working in a GP practice in another life and whatever. So the first thing you do once you know that the hemoglobin is low is you have a look at the MCV, the mean cell volume, which basically tells you how big the cells are. So they can either be macrocytic, in which case they're big, which means that that number is enlarged. They can be normocytic, which means that that number is in the normal range, or they can be microcytic, which means that it's less than the normal range and therefore the cells are small. And then it's nice to think of it that way because you can split up the causes of as Jack's showing you here on that slide into roughly what's more likely given that pattern of anemia. But again, as I've said, it's not always clear cut, but it's a good starting point. And there's various causes, as you can see, depending on the size. So that typically, more often than not, a microcytic patient will be iron deficient. There's a couple of slight caveats to that, particularly the thalassaemics who often get iron overloaded with lots of iron tablets when they don't need them at all. But anyway, Jack, was there anything else that you wanted to mention on this slide in particular, or?
No, I think we're going to go through a couple of them, like just iron deficiency and B12 and folate and hemolytic, which are sort of quite common ones. And yeah, so I think we'd all say this is probably the sort of anemia we know the most about, or the ones that we're all probably the most familiar with, I would say. And that's usually due to has there been a what we think is, has there been a bleed anywhere like the GI tract, for example, whether a upper GI or lower GI bleed. Again, it could also be due to a malabsorption, so sort of a celiac disease picture. It could be a physiological, so someone's pregnant and has higher demands, or it could be a GU system cause. So is it somebody with heavy periods, or is it from the bladder that's bleeding? And then we just want to discuss about. So if this is slide sort of thinking about iron deficiency versus anemia of chronic disease, because both of them can have an MCV which is low, and it can be sometimes quite hard to differentiate between the two of them. And I think what you tend to find is the ferritin. So the ferritin would be down in iron deficiency, but would be raised in anemia of chronic disease, because ferritin's a bit like CRP or platelets. It's an acute phase reactant. So if someone's got anemia of chronic disease, say secondary to like an infective endocarditis, for example, their ferritin, because there's an inflammation, the ferritin's going to be high, a bit like the platelet count or their CRP or neutrophil count. So I think that table is a good way of sort of, if it's not quite clear, to go through things and to try and pin down which one it is.
I think the important thing to mention when looking at iron deficiency, so the best test that you have is ferritin. If the ferritin is low, then the patient is iron deficient. But outside of that, the tests all have their limitations, and it requires a bit of sort of experience and just that little bit of knowledge of how the tests work to really sort of unpick it. So it's not that infrequent that I get referrals through about what is actually going on here. And sometimes it's really hard to tell even from some of these tests. I won't bore you to death with all the assays and how they work, but sometimes it's tricky, and sometimes the outcome is actually, why don't we just try a bit of iron and see what happens? So it's good to check the ferritin, but having a normal ferritin can sometimes indicate iron deficiency. So as Jack said, if you've got inflammation going on, then you'd expect the ferritin to be really high. So therefore, if it was normal, is the patient actually iron deficient? And it becomes quite complicated. So low ferritin means iron deficiency, but then outside that, it's quite tricky, and it takes quite a lot of experience. And I can try and send around a bit of a sort of how-to afterwards, a bit like this table, but it is not straightforward all the time. Yeah, sorry, Jack.
Sorry. And then thinking about iron deficiency anemia investigations, and again, this is more clinic or general practice based. And I think what we always tend to think of, you always hear the phrase, "Oh, they need a scope from the, they need endoscopy and colonoscopy," and we jump straight to those things and think that's what we need to do. And actually, there's a couple of sort of more simple things above them, like a non-invasive simple urine dipstick. Could this patient be having a bleeding because they've got a new, a bladder carcinoma, for example? So simple things like a urine dipstick, celiac serology, and then going more on to think about things. So do they need an endoscopy or colonoscopy, or instead of the colonoscopy, if it's a very frail patient, a CT colonogram? And these are probably, you think, maybe if you look at the NICE guidance for 2-week wait for cancers, this is, especially in patients, over the age of 55 with an iron deficiency that you've not got to the bottom of, then you're thinking this patient needs an endoscopy and colonoscopy, really. And again, the other thing to think about in the female patient is, do they need a gynecology referral if it's post-menopausal bleeding? And in terms of managing the iron deficiency, I guess the most important thing is to manage the underlying cause, whichever that may be, and then to give iron supplements. And again, a lot of these patients can be quite old and frail, and it may be tricky for them to tolerate the ferrous sulfate because of side effects like the stool. And so you try to get them on a dose that they're able to take, really. And sometimes if people can't tolerate oral ferrous sulfate, then they do need IV iron supplementation, so things such as Fer-Inject, or for example. Is there anything anyone wants to ask about that?
I'm okay about that.
No, we're okay, thank you.
And then sort of moving to the other side of anemia, so the macrocytics, patients that have a large MCV, we've got large red cells. So folate is so it's the main dietary source is through leafy vegetables, and so a deficiency therefore can be due to a poor diet, maybe in frail elderly patients that aren't eating a great deal. Again, malabsorption like celiac. So celiac patients may have a mixed hematinic disorder like this iron deficiency and a B12 folate, and it can be due to medications like phenytoin or methotrexate. And then B12, so that's absorbed in the terminal ileum, but it's the intrinsic factor helps that absorption, and the intrinsic factor is made in the parietal cells of the stomach, and that's the reason why we're talking about that is things like, as mentioned earlier, pernicious anemia can cause that. Diseases of the ileum, such as Crohn's disease, or the patients had a gastrectomy in the past. And I think the important thing to say about B12 is, and it's something that you will see occasionally. It's not completely rare. It's patients may have neurological presentation. So we tend to think it's because of peripheral neuropathy. So pins and needles, or in the lower extremities, or it can cause a subacute combined degeneration of the spinal cord. That would have more sort of central signs on examination. So brisk reflexes and increased tone, rather than this peripheral neuropathy that would have decreased reflexes. So that's something that's something that you will see occasionally. Is neuropathy secondary to B12 disease. Anything there anyone would want to ask about? And then moving on to sort of hemolytic anemia. And And it's a disease where there's a reduction in the normal lifespan of a red cell, and it's got a long and exhaustive list of causes. And I'm sure if you look at any textbooks, there's loads of diagrams of how to break it down. And I think it's quite tricky, unless you're a hematologist maybe, of going through the different causes. But I think you can. One way of thinking about it is it congenital or acquired initially? And congenital causes is lots of, rare causes, and then the acquired side. Then you want to think about, is this immune mediated, or is it non-immune mediated? And so again, this hemolytic anemia, this would be a patient again it's got an anemia that you can't explain, and it's got a high MCV. And so in the next slide, we'll just go through what investigations you would do in this. So again, this would be a patient with a macrocytic anemia, so somebody with a high MCV that you can't explain, and so you've done sort of things like a B12 and folate, and they're normal. So other things that you would do, and you'd get asked this not infrequently on a ward round, somebody might say do a hemolysis screen. So they'd have a high reticulocyte count, and reticulocytes are sort of immature cells. So because there's a breakdown of the red cells, then the bone marrow is overcompensating by pushing out lots of immature cells. Other tests you would do is an LDH, and which would be raised, and hepatoglobin, which would be low. And the other thing, the patient may sometimes actually be jaundiced, so they've got to have a raised bilirubin. And so these things would all point towards if these things are all, so if you had a raised LDH, raised reticulocyte count, raised bilirubin, and reduced hepatoglobulin, then you would think, could this be hemolysis? And then the last few things we're trying to think about what could be the actual cause of it, because as we said, it's a very long list. And so as we spoke earlier about, the DAT test, or Coombs test, and this is one we're thinking, is this an immune mediated or non-immune mediated? And so the Coombs test is what it's trying to do is detect antibodies that are stuck to the surface of red blood cells. And so if it's positive, that suggests an immune mediated cause. I don't know, Jack, would you want to go into more detail on it at all?
So I think we're obviously running out of time a little bit, but I think hemolytic anemia is just one of these really nice things where every test that you do makes sense, and as to why it's happening, and it's just this really kind of, for slightly nerdy people like me, really nice thing to watch, diagnose, and then watch as it gets better with treatment. But I think there are a number of causes of hemolysis. One of the main differentials when you're trying to work out what the cause is, if you think someone is hemolyzing. So the first sort of 1, 2, 3, 4, 5 points are to try and determine if you think someone is hemolyzing or not hemolyzing. Once you feel that someone is hemolyzing, then the question is why are they hemolyzing? And then the first question that you ask yourself in that setting is this because of an immune process or a non-immune process? So the best test that we have to determine that, not the only test, but one of the best tests that we have up front, is something called a direct antigen test. This is that DAT test that you asked about, or sometimes it's known as a Coombs test. And effectively what you're trying to decide with this test is, are the red cells that are in your blood coated with an antibody that has been formed against them, like an autoimmune condition, that is flagging them up for being broken up. So naturally in our body, we break up red blood cells when they get too old, but what's happening here is that the immune system's decided it doesn't like the red blood cells, and it's telling the immune system to get rid of them, even though they might be quite young and healthy, so you're getting faster breakdown. So a DAT test tells you if this is immune or not immune, but it's not a perfect test, and it takes a bit of interpretation. Very, very frequent that we get referrals with positive DATs. I think about 10 to 15% of patients in hospital will have a positive DAT without any evidence of hemolysis. So it does take a little bit of interpretation. If you had more time, I could tell you about how it all works, but it's not that it isn't interesting. It's not that relevant, I guess. But it's just that test that basically is telling you whether this could be an immune-mediated, so like an autoimmune hemolytic anemia, or a non-immune mediated hemolysis. And that helps you split apart the causes and what you think might be going on, and therefore what the best treatment would be. And I think that's what the rest of the tests that Jack's talking about on this slide are as well, to try and determine what the cause might be once you've determined that someone is hemolyzing.
Cool. Was there a question there? Sorry.
Okay.
Did somebody put their hand up? Sorry.
Yes, I was just going to ask. So, if you had a positive DAP test, would that would insinuate that it's an immune problem or a non-immune? Which is a positive one that it's an immune problem?
That's right. Yeah.
So when it is, sorry, Jack. I was going to say when it's truly positive, then yes, it would indicate that there's an immune process, but it comes in sort of varying degrees of positivity, so from 5+ to 1+ or 0, and depending on what's going on, we'll just ignore some of those tests and results, or it might sort of be more interesting, and depending on the whole situation. So it's not just a test on its own that's going to give you the answer. It requires a bit of experience and interpretation as well, but it's just one of those tests to think about with that patient with macrocytic anemia that's relatively acute, that it might be something that's going on, particularly if they've got high bilirubin, which is pretty much everybody that you'll meet on Huntsman. Where's gastro now? Huntsman 5. So basically every single liver patient will look like they're hemolyzing and have a positive DAT, but I'll guarantee that most of them are not. But anyway, we won't get into this. It's just that the liver makes it look like they are, basically, but it's not.
Thank you.
And again, as Jack said, the last three things in the list are, again, just thinking about if this is, what could be the cause of it. So an autoimmune screen, so things like a lupus can cause a hemolytic anemia. A viral screen, because a viral hepatitis can be associated with a hemolytic anemia. And you also think about doing a CT tap, because there's an association between things such as CLL and an autoimmune hemolytic anemia. But again, that's further down the list of looking at the causes. And so again, how to manage this? If you think somebody's hemolyzing, then yes, you need to liaise with hematologist as a specialist problem. You want to try to avoid transfusing this patient, unless they're unstable. And again, you'd want to liaise with the hematology team and the transfusion lab. And really, like most things, you need to treat the underlying cause. And again, if they're in hospital, thromboprophylaxis and replace the folic acid if that's low as well. And I think that's that for hemolytic anemia. And that's it. Is it any other questions at all?
No, I enjoyed that. Thank you very much.
That was good, yeah.
I'm okay, thank you. Yeah, that was
Thanks. Apologies about the delay again.
No, it's fine. Could you possibly send us a presentation, please?
Yeah, if you is there someone? Should I send it to? Is there any? Yeah.
Or Jack can send it. The other Jack.
I've got it, Jack. I'll forward it on.
Thank you.
Naz, because I'll send you another feedback form for this one for Jack, and Jack, I'll forward you them if we get any